The following presentation is copyrighted by Medscape Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape Education. The following podcast is supported by an independent educational grant from GlaxoSmithKline.
Hello, I'm Dr. Jay Wish, Professor of Clinical Medicine at the Indiana University School of Medicine in Indianapolis, Indiana. Welcome to this program titled New Treatment Strategies, Where Do They Fit In? Part of the Updates and Advances in Anemia of Chronic Kidney Disease series. Joining me today is Dr. Bruce Spinowitz, Associate Director of Nephrology and Vice Chairman of Medicine at New York Presbyterian Queens Hospital and Professor of Clinical Medicine at the Weill Cornell Medical College. Welcome, Bruce.
Hi, glad to be here. Thanks for the invite.
By means of introduction, anemia is a common complication of chronic kidney disease, or CKD. The prevalence of anemia in patients with CKD increases as disease progresses, and about 50% of all patients with stage 5 CKD have associated anemia. This is the final podcast in the 6-part podcast series on understanding and managing anemia in patients with CKD. In this episode, we'll focus on where do the new treatment strategies and how do you use them in your patients with CKD anemia. I will ask Dr. Spinowitz about the risks and benefits of the new therapies and how to implement them in the management of patients with anemia and CKD. Bruce, let's briefly review the hypoxia-inducible factor, or HIF system, and how it affects erythropoiesis.
Sure. It's actually a very elegant system. Let me just state it first in a brief sentence, and then I'll elaborate a bit. So erythropoietin gene expression is controlled by these HIF factors, the hypoxia-inducible factors, and these factors themselves are oxygen labile, essentially controlled by the content of oxygen. So you have this very beautiful loop where the factor that induces erythropoietin production is itself controlled by the content of oxygen. Basically, all cells need oxygen, and to the extent that the cells and organs have to sense any deficiency in oxygen and defense against that deficiency, this HIF biology has essentially been characterized as the main sensor and regulator of the response to low oxygen content. So in brief, the system consists of gene regulators called the hypoxia-inducible factors. It is actually a dimer, a heterodimer, HIF alpha and HIF beta. HIF alpha has been shown to be the factor that is oxygen dependent. So in the presence of normal amount of oxygen, HIF alpha is produced. It is hydroxylated and essentially tagged for destruction through the von Hippel-Lindau protein and ultimately the proteasomal degrading machinery. In the presence of a deficiency of oxygen, hypoxic state, which could be anemia, could be ascent to a high altitude with less oxygen content, that HIF alpha is not hydroxylated, moves into the nucleus, combines with HIF beta, and in so doing regulates production of an array of genes now shown to be in the hundreds, if not thousands. But one of those genes that's regulated is the production of erythropoietin. So every cell has this system, and obviously depending on what the mission of that cell is, will produce or not produce the protein. With respect to erythropoietin, we now know that it is the tubular interstitial myofibroblast that is responsible for the production of erythropoietin. So this tubulointerstitial fibroblast, perivascular fibroblast, is responsible not only for the sensing of oxygen content. It's located in an area in the kidney that is relatively hypoxic and therefore can sense small changes in oxygen. With a decrease in oxygen content, either from anemia or ascent to high altitude, that deficiency of oxygen prevents, essentially does not allow for the hydroxylation of the HIF alpha. HIF alpha moves into the nucleus, binds with HIF beta, and eventuates in the production of increased erythropoietin. So that's the closing of that loop. The enzyme that's responsible for this hydroxylation, prolyl hydroxylase domain enzymes, do any number of things throughout the body, including collagen biosynthesis, methylation of DNA. But in addition, prolyl hydroxylase enzyme with oxygen in the presence of iron and ketoglutarate hydroxylates the HIF alpha 2 proline residues, and that is essentially what leads to its degradation. With a deficiency of oxygen, there is the eventual increase in erythropoietin production. The HIF system does operate, as I said, in all cells, and depending on the particular cell, is responsible for other proteins that are part of essentially delivering more oxygen. So that may very well be angiogenesis, change to anaerobic metabolism, and also specifically with respect to erythropoiesis, a significant impact on iron absorption and mobilization.
So, given the fact that the kidneys are the major source of erythropoietin after birth, is it possible for the kidneys of patients with late stage or end stage kidney disease to be stimulated to make more erythropoietin or EPO to raise the hemoglobin level if the cells responsible for EPO production are severely decreased in number?
Yeah, so we certainly see certain instances where, in fact, the significantly damaged kidney can still respond with an increase in erythropoietin. So we see this from the presence of a CKD patient who has an acute bleed, where there is an increase in erythropoietin production, and in fact, their response. Another example, as I mentioned earlier, is ascent to a higher altitude. We see this even in our end stage patients who go from a lower altitude to a higher altitude, have an increase in hemoglobin and or decrease in their need for erythropoietin replacement. So certainly we see that the kidney, the diseased kidney, can respond with an increase in erythropoietin.
What are the drugs that are in development that increase HIF in the kidneys and thereby increase EPO production and hemoglobin levels?
So with an appreciation of the pathway that I sort of outlined briefly, the prolyl hydroxylase domain enzyme is became the focus of a means of manipulation of this HIF system. And by that I mean it was clarified exactly what is a locus by which this enzyme is hydroxylating the proline residues. The characterization of that enzymatic locus led to the development of a small molecular weight organic compounds that could interfere with that enzymatic activity, and that is essentially the focus of pharmacologically manipulating this intricate system. And there are a number of compounds that have been developed and have now advanced through phase 2 and phase 3 trials, which have validated the ability to manipulate this system by interfering with this enzyme.
Can you give any more details on how these drugs actually work?
So through the phase 2 trials, the characteristics of these compounds and what they were doing was elucidated. These are small organic compounds taken orally, various half-lives. So they may be taken either 3 times a week or on a daily basis, depending on the half-life. And what was seen was that by interfering with this enzymatic activity, the prolyl hydroxylase domain activity, these inhibitors led to a relatively small and transient increase in erythropoietin. This is in contrast, by the way, to what we currently see with use of recombinant human erythropoietin, that whether it's given intravenously or subcutaneously, no matter which of those recombinant products is used, the erythropoietin levels that are achieved are actually much higher than the bone marrow can even respond to. With respect to the prolyl hydroxylase inhibitors, however, the erythropoietin increase was relatively minimal, but sufficient to induce the pharmacodynamic impacts. And that is, we saw an increase in reticulocyte formation after a few days, and an increase in hemoglobin in a smooth, predictable fashion over the ensuing 4 to 6 weeks, much as we have come to see with recombinant human erythropoietin. Um, in addition to which, there are many effects on the erythropoietic process that are dependent on HIF, and that is with respect to iron kinetics. Um, Iron, similarly, absorption and mobilization is under the direct and to a certain extent indirect control of this HIF system. What was shown in those earlier studies was that there is increased iron absorption with use of these prolyl hydroxylase inhibitors and increased iron mobilization. The mechanism by which this occurs, that HIF controls many genes, and some of the additional genes besides erythropoietin production are the regulation of enzymes that are responsible for duodenal transport of iron, the oxidation and reduction of iron, increases in transferrin, the major transporter of iron, um, uh, uh, transferrin receptor, erythropoietin receptor, a host of genes that are regulated by HIF that lead to this coordinated erythropoiesis of increased erythropoietin and increase availability of iron. So that's sort of the data that was gleaned from the phase 2 studies.
Why might the oral route of administration for the HIF PHIs be an advantage over currently available treatments for CKD anemia?
As you alluded to in your introduction, CKD anemia is significant. There are many patients who go untreated, as evidenced by the increased use of erythropoietin when the patient moves from the outpatient setting to the dialysis setting. The iron availability is less in the outpatient setting. So certainly, CKD anemia management prior to dialysis, there is a challenge in terms of availability of the compounds, and even on dialysis, uh, large numbers of patients are undergoing home dialysis. The potential availability of an oral compound as an alternative, as an additional means of treating CKD anemia, both in pre-dialysis as well as dialysis, could be significant.
Bruce, do these drugs have any other beneficial effects on the physiology of red blood cell production that you didn't mention?
Well, as I said, it's this coordinated erythropoiesis in terms of not only increased potent production in a minimal, transient, but effective amount, as well as the coordination with the iron kinetics. There is some suggestion from the earlier studies, the phase 2 studies, and to a certain extent from the phase 3 studies, that patients who were relatively EPO resistant may be more responsive to these compounds. Um, we have a number of surrogate markers of EPO resistance, large amounts of requirements for erythropoietin, elevated C-reactive protein, elevated ferritin, these markers of resistant patients.
What are some of the potential disadvantages of these drugs based on their mechanism of action to increase HIF?
Some of the concerns, obviously, as I stated earlier, is that the HIF system impacts hundreds, if not thousands, of genes in terms of regulation and control. So there is the potential for off-target effects, uh, and that certainly was the focus of the phase 3 studies. Um, Three of the compounds had extensive studies, not only for efficacy, but also for safety, looking at safety endpoints. Um, Issues that were raised with respect to recombinant human erythropoietin based on some of the earlier trials that looked at near normalization of hemoglobin in the CKD and the ESRD setting, suggested that there are concerns about thromboembolic events, increased incidence of strokes, cardiovascular endpoints. I'm alluding to the Choir and the CREATE, the normal hematocrit study, the TREAT study, studies which um, actually sought to look at the potential impact of normalization of hemoglobin in the CKD arena, and led to concerns that increasing hemoglobin to near normal levels was associated with these thromboembolic events. As a consequence, we know that the hemoglobin targets have been lowered in the US to the 10 to 11 range. So there is still the concern that any alteration of hemoglobin could lead to potential cardiovascular adverse outcomes. And towards that end, the three compounds that I referred to that had large safety studies did look at those cardiovascular endpoints. The general endpoints were a MACE endpoint, which looked at all-cause mortality, non-fatal stroke, and non-fatal MI as a non-inferiority endpoint. The other dual endpoint, of course, of this study was to show non-inferiority for efficacy with respect to correction and maintenance of hemoglobin. One of the other areas of off-target concern was the concern that this system has been shown to be associated with um, development or progression of malignancies by virtue of one of the enzymes that allows for vascularization, maintenance of vascularization in the setting of tumors. So the concern was that there may be this off-target effect if used in the CKD arena of development of malignancies. But the studies have specifically looked at some of those off-target potential adverse events experiences.
Bruce, have any of these agents been approved in the United States or in the rest of the world?
So in the United States, as I mentioned, there are at least 6 that have been looked at in terms of efficacy and safety. The 3 that have had the large, extensive safety studies that have been presented for consideration in the U.S. are roxadustat, vadadustat, and daprodustat. But based on somewhat smaller studies, these drugs do have approval, some in Japan, China, and Europe has approved one of those compounds, roxadustat, um, for use in CKD anemia, both non-dialysis as well as dialysis.
What have been some of the issues that have delayed their approval in the United States?
The studies that were looked at extensively by the FDA in the U.S. First with respect to roxadustat, which was the first one that was considered. All of them, I would hasten to say, have been shown to be effective in terms of increasing hemoglobin. Most of the studies have been comparing the prolyl hydroxylase and domain inhibitors to active control. So the studies were by and large, as I said, designed to show non-inferiority with respect to efficacy, which they uniformly achieved. There was no question that the compounds, based on the data that was accrued in phase 2 studies, applied to phase 3 in terms of dosing intervals, showed that these compounds indeed raise hemoglobin and or maintain hemoglobin in the range comparable to the active control. Um, in addition to the efficacy studies, of course, there had to be the safety studies, with the major endpoints being, as I said, all-cause mortality and non stroke and MI. Um, the With respect to roxadustat, um, the considerations were a little complicated by virtue of a number of issues. So whenever one does a non-inferiority study, there is obviously a confidence interval. Non-inferiority would mean the statement that the active new compound compared to the comparator compound is no less safe, and there was a range of confidence interval. With respect to roxadustat, one of the issues was there was a difference uh, between the upper limb of the confidence interval that the FDA was willing to accept. In the case of Roxa, it was slightly in excess. In addition to which, the FDA is fairly clear in their requirement with respect to non-inferiority trials that they be compared to a already approved compound in terms of the comparison for non-inferiority, but there be a sensitivity study. Um, so long studies that look at safety are complicated by the fact that there are dropouts of patients. That dropout may be differential in extent, uh, and it creates a bit of a conundrum in terms of evaluating the non-inferiority of the compounds. And they not only ask for typically an on-study analysis, but also an on-treatment. That is to say, if an event occurs after treatment is stopped, there is a finite period of time where that is still included in that analysis, and that's so-called on treatment. Uh, and what the FDA saw with respect to roxadustat was that the sensitivity analysis did not meet their requirements. In addition to which, they saw safety signals with respect to thromboembolic events, which are serious adverse experiences of concern in this arena. In addition to which, they saw an increase in some other um, serious adverse events, including sepsis and seizures. As a consequence, the FDA did not approve roxadustat. The European Union, which did approve roxadustat, did have a caution, was aware of this data, and their recommendation was that patients that are stable on a current ESA not be switched to one of these HIF stabilizers. Um, with respect to vadadustat, the uh, non-dialysis dependent patients, anemic patients, did not achieve non-inferiority. That is to say, the upper limit of the confidence interval exceeded the agreed upon level. And so it was clear that because they did not meet non-inferiority for safety, the FDA did not approve use in the non-dialysis. But even in the dialysis population, there was a safety signal in their assessment with respect to thrombotic events, particularly AV access clotting. And so they did not achieve approval from the FDA. An advisory committee was impaneled with respect to the non-dialysis data on daprodustat. That advisory committee did not recommend approval, and the reason was that they saw again some increase in thromboembolic events in the non-dialysis population, and also some concerns about heart failure hospitalizations. With respect to dialysis-dependent uh, patients in the daprodustat study, the advisory committee did recommend approval, feeling that the benefits do outweigh the risks.
Daprodustat was approved by the FDA for treatment of anemia in patients on dialysis starting 4 months after the initiation of dialysis. This approval occurred on February 1, 2023, and it's expected that the drug will be launched in the United States sometime during the later first quarter or second quarter of 2023. There are a number of black box warnings on the label for daprodustat. Most of these are borrowed from the ESA label, since the clinical trial for daprodustat in dialysis patients compared it to ESA and shows safety non-inferiority. That being said, most of the safety issues with the ESAs that include increased incidence of major adverse cardiovascular events and thrombotic events have also appeared on the daprodustat label. There is also a labeled warning about esophageal erosions, which did not occur in the dialysis patient study and was actually transferred from some of the data in the non-dialysis patient study. But other than that, if you look at the daprodustat label and its warnings, it is overall pretty similar to ESAs, again, because the phase 3 clinical trials demonstrated safety non-inferiority. We expect that this will be an attractive option for patients on home dialysis, where oral administration may be much more convenient than the parenteral administration that's required for ESAs. And there may also be a subset of patients on in-center hemodialysis that would be considered for daprodustat because of the ESA hyporesponsiveness.
Thanks, Bruce. That concludes my questions. Do you have any final comments?
No, I think this has been this has been a very interesting and exciting ride for the nephrology community, and I think our patients. I think there is an unmet need for an oral a compound that would enhance hemoglobin, and needs further clarification with respect to some of the safety issues. I'm looking forward to having at least one of those compounds available for a sector of our CKD population in the near future.
The HIF-PHIs are a promising new class of drugs for the treatment of anemia in our patients with CKD. Their oral route of administration makes them particularly attractive for patients with non-dialysis CKD and on home dialysis. They have been shown to be equally effective as ESAs in increasing hemoglobin levels in randomized clinical trials. I'd like to thank Bruce for a great discussion. I really appreciate your sharing your expertise. And thanks to our audience for participating in this activity. Please join us for the remaining 5 podcasts in this series, Updates and Advances in Anemia and Chronic Kidney Disease. We hope you enjoy the rest of your day. Please continue on to answer the questions that follow and complete the evaluation. We really appreciate your feedback as it helps us develop future educational programs.